I would love to bring up Dr. Mickey Segal to the podium. Dr. Segal has been with us for many, many years. He's been a really great supporter. When our listserv was active, he would always jump in and answer questions. And he was, one of the few physicians who really rolled down in the dirt with us and kind of helped us along that way. And he's a Harvard Medical School trained pediatric neurologist. So with extensive credentials. One of the things he's done is develop a software, which he can talk way more about, but called Simulconsult, where you put in certain symptoms and it kind of steers you in the right direction and can help make rare diagnoses such as the ones affecting us. So without further ado, here he is.
Thank you. Let me explain what we're going to be doing here, and then I'll give you a few more details about me so you understand where I'm coming from, because it can be confusing because I seem like I'm coming from several directions. So what we're going to do now is we're focusing on you and your stories, and people will get up and tell a little bit about themselves and their experience, and then I will free associate from that to make some general points about understanding from a clinical or a research point of view what's going on. And I bring to this several types of background. One is I'm a pediatric neurologist, and so I'm familiar with the clinical background, but I'm also a neurophysiologist, and I first became involved in periodic paralysis based in part on my expertise in the electrophysiology of epilepsy, which is another ion channel type of disorder. But then I found a form of attention deficit disorder that seems to have a real overlap with hypokalemic periodic paralysis. And then some members of this group saw the papers and said, no, it's actually even more related than you think it is. And there's a form of periodic paralysis where people also have ineffectiveness of the local anesthetic lidocaine that you've seen mentioned and is mentioned up there. And there are families in which the periodic paralysis and the lidocaine ineffectiveness run together. There is some fraction of the general population where lidocaine ineffectiveness is it may be 5%, or it may be, in some places, it may be up to 10%. And we're trying to sort that out. We just got a grant from the NIH to do some of that, and we're figuring it all out, and I may tell you a little bit more about that. But and some of those insights came together from doing the software to diagnose rare diseases, when somebody would come to me and they would think, oh, if you're doing diagnostic software, you must know everything about every rare disease. But in fact, the reason one does diagnostic software is one wonders, how can one possibly keep in your mind all these rare diseases? And so anyway, I may show, if we have time, I'll try to show you the software tomorrow, just to give you a sense of how doctors think and why they ask about this or that, or so forth. And we also use it as a front end for genome analysis. And
sorry, it's cold in the room. We understand that. So there are blankets over there. If you want one, just raise your hand. Shelley will give you, and we're trying to address it. So anyway, so that's where I'm coming from. But we're starting out with you folks, and we did this for the first time last year in Arizona. And someone will go around and hand a microphone to one of you who will tell about you and tell about yourself. And then if there's some interesting point to make from it, I'll try to make it. And while people are deciding who's going to be the first to talk, it was mentioned earlier about about fluorescent lights, and that people actually have paralysis episodes from exposure to what is probably not the fluorescent lights themselves. It's probably to the electrical power from that. And we found out about that through you folks. And as you've heard, one of the big dangers in having hypokalemic periodic paralysis is that people tell you you're crazy and you're imagining it. And
I have this sort of frightening memory of when I was a resident in neurology, how they took us to a patient's bedside and demonstrated how you could tell when somebody was faking. And it haunts me when I think back to that this person could easily have had periodic paralysis, and the people who are teaching me these rules of thumb just didn't teach me good rules of thumb. And I've really tried very hard to pester neurologists to get this one right. But with the electromagnetic field, not only will the patient be told that they're crazy, but probably the doctors describing it will be told that they're crazy. So once we find the genetic basis for the lidocaine ineffectiveness, we hope to go back and then study people who have, we think it's the lidocaine ineffective type, who tend to have the problem with the electric field. And so we think that if we study it in the context of a genetically proven mutation, nobody's going to tell us we're crazy, and nobody's going to worry that they have to take down every power line in the civilized world. Okay, somebody ready to get this going? I was at an Irish music pub crawl last night where people had to get up, and people from the audience to get up and sing, and I think that was probably harder to imagine than people doing this, which worked out really well when we did it last time.
Hi, I wanted to ask a question on behalf of my son Sam. He's got Anderson Torwell. He's just turned 16, and like all 16-year-olds, he's really interested only in fitting in. He wants to go to the gym with his mates, but he's having a lot of problems with pain in his arms, lifting, and his wrists and his elbows. And we're getting a lot of conflicting advice. So my question is, there's one physio telling him not to lift anything at all, no weights at all, just to lift his own arm. And there's another physio telling him to lift until he feels pain and then stop. And he says that's no good because that's only about 30 seconds. And then there's another physio saying, push through the pain. But we don't want him to get tears in his muscles or any lasting damage. So what is the proper advice, please?
Okay, I will discourse on that a little bit, but I think there's other people who could say more than I could about that. So I guess this fits the format. Okay, so in general, what we're trying to do is, here's my story, but this is sort of formulated into a question, but that's fine also. I think what the point that Dr. Weber and others have made in the past about the permanent muscle weakness is the concern that when you have lots of sodium coming into the muscles, that you actually are leading to long-term damage with this. So in general, exercise thing, people talk about push through the pain and so forth. I think in periodic paralysis, the concern would be that when you're doing that, you're actually leading to permanent weakness. And I don't know enough about ATS to know how bad the permanent muscle weakness is with that. Maybe Dr. Weber, Dr. Cannon could say more about that. But I would be concerned about pushing through pain. One of the good themes in periodic paralysis is that gradual things are important, and specifically gradual in terms of don't even stop abruptly, that try to go up and go down in a very gradual way.
Good. Do you guys have any comments on that?
I agree with that. I wouldn't fear pain. I think the pain level is achieved, that's absolutely enough. And of course, you need your muscle to function, but you don't. You should not overstress them, of course. Yeah. Yeah, but the point is, what happens on the long run? This is the thing with the sodium inside the channel, inside the cell. I've just mentioned the discussion on the table. I have two patients who are now in their 70s. They were mountain climbers when they were in the 30s and 40s and went to the Himalaya and with hypo-PP, genetically diagnosed hypo-PP, and they functioned very well. And they in the age of 40 or so, the myopathy, let's say, started and became clinically relevant. And now they have a severe proximal vacuolar myopathy. But in his case, he started on medication soon. And my patients, I mentioned, they did not start on medication until they were affected with permanent weakness in their age of 40. And that's the difference. Yeah?
So let's pass the microphone to Gabe, because I asked his mother about this, but I want to hear directly from him. So, Gabe's story was just amazing in terms of most of us would have a huge amount of trouble doing that amount of exercise. For the Scottsdale meeting, most of what I packed was my rollerblades, and I rollerbladed 60 miles or so while I was there. But still, if I tried to do the stuff that Gabe did, I would just have a severe muscle weakness at some point. And so specifically, I asked your mother what you did to deal with this this trigger, which Dr. Weber discussed, of when you drop off your activity abruptly, you start getting that you get this overshoot where your potassium is driven low because the pumps that are getting rid of it while you're exercising are sort of don't know that you're about to stop, and also the whole pH effect goes away, and there may be adaptations for that. And so your mother told me the answer was that you just kept walking around and doing stuff. And can you describe to us what it's like to do you feel this issue, and what do you do about it, and what are good strategies for coping?
Yeah, I do. I definitely do. When I'm riding, I feel the best, probably, when I'm riding or doing activity. And when I stop, I usually try to have a really good warm down, like very mild exercise after I am going hard. And once I finish, I try not to stop moving until I've totally kind of calmed down. And usually more than 10 minutes, I try to walk around and do that. And I don't, usually I feel worse in the morning once I wake up, and then I get on my bike, and then I start going, and then I feel better. And then when I stop, I'm still okay. I never really feel that bad after I ride, as long as I warm down well. But there have been times when I just get off my bike because I crash or fall over or something happens, and I get in the car and drive in the van. And definitely when you get out again, it takes a while to get back up, I think.
Because it must be particularly difficult for you, because I think of myself of not having any of these conditions, and if I'm really tired, I just stop, and that's fine for me. But it's a much more difficult situation if you know that you can't get to the point where you're so tired that you have to stop, because stopping is a problem. And so you have to stop slightly before then, and then gradually ramp down.
Right, yeah, and I think that's what happened with my triathlon paralysis, is when I just stopped, I couldn't do anything else. But usually I have enough left in me, I think. I think it's pretty hard for me to totally waste myself, but I think also just the muscle fitness that I have after riding so much really helped with the not feeling as bad afterwards, maybe.
Great.
I mean, the net is that for any one person, there is a trial and error. There is a trial and error that happens with exercise, and you're going to try one time to push really hard, and you're going to see the after effects is either you did it, you're okay or not, and other times you're going to not push that much, and you're going to see that you're also not getting that strong as you want. And at some point there's a happy medium, and you're going to find maybe it's more cardio, maybe it's more weightlifting, maybe it's not, resistance versus not resistance. So part of this is trial and error. I will say, it's just also from anecdote of working out hard, that sometimes I'll work out really hard in the morning, and in the evening I'll be okay. First of all, I'm going to be really hungry after working out, so my caloric intake is going to be more. And in order just to keep up with my basic caloric needs, that puts me in attack. So then I take more potassium. So I'll prophylactically take the same amount of potassium as I did before working out, same amount again that night, so that I don't wake up at 4 in the morning not being able to move. And you play that game a little bit, and then you also may recognize that over time your potassium needs increase. And what I had initially written in this article I wrote back then, that 60 milliequivalents and don't go above 100 without checking, and that's probably too conservative if you think about it. And there's many people who need a whole lot more than that. So it's a little personalized, and maybe there's no hard, fast rules yet.
One of the things that Jake mentioned that you should all know about is he's written what, as far as I know, is the best article about how to treat hypokalemic periodic paralysis. I came in mostly from the diagnostic area, and even when I was seeing patients, I wasn't seeing a whole lot of patients, and I was much more involved in research and in diagnosis. But his article about how to treat hypokalemic periodic paralysis and give potassium and other medications is the best article that I know of, and we refer to it often as we're doing various things and mentioning. You'll find in some of the general articles, like some of the general overall articles, like in Gene Reviews and so forth, and a few of us, together with the late Dr. Frank Lehman Horn, put together what we called an owner's manual for hypokalemic periodic paralysis, where we basically had people on the listserv said, write up all this stuff so we can just sort of have a central document with it. And they submitted the questions, and we wrote some answers, and they said, no, change this, and so forth. And so we have that up on the web. If you just search for patient owner's manual, hypokalemic periodic paralysis, you'll find that, and has a lot of helpful information. And we specifically refer to this Dr. Levitt's article on treatment as well. Okay, next singer.
Hi, I find that throughout my life, my teens, my 20s, 30s, it's during exertion that would bring on an attack. And I was diagnosed as normokalemic way back in primary school. I also find that periods when I'm very nervous, if I'm about to make a speech, and I remember a while back I had to make a speech, there were cameras and so on, the whole lot there. And I found that if I drink lots of water, really, really, really hydrate, it can stymie an attack. Now, I'm on no medication of any kind, and I suppose that's why I'm here. I just want to know, what should I do about all of this? I had to get a bridge fitted in my mouth some time back, last year, and it involved having a root removed. I couldn't get out of the dentist's chair. Now, I made an excuse to say my legs had gone asleep and so on, and I stumbled out of the room and all of that. My next appointment, the dentist said, look, he's putting a bit of adrenaline into this because he said your heart may, pound a bit and so on. I couldn't get out of the chair. Now, I started to put two and two together, and I emailed the PPA, and it was yourself, Dr. Segal, in fact, got back to me and said, don't avoid adrenaline. Whatever happens, avoid adrenaline. I was
about to say that again, but I'll give some more details.
No, it was yourself. So my next appointment, I very, politely said it to the dentist. He was a dentist I wasn't familiar with. He not my usual dentist. And I said, I've got something that's quite rare. I said, you may not have heard of it, but I said, run it past me, and I told him what it was. And he said, you're right, I haven't heard of it. And I said, could you avoid adrenaline, please? Well, he said, I can give you anything out of this drawer, he said, but it's all rubbish. He said, it won't really make any difference. And I said, well, just maybe we'll try it and see what happens. So I went through a bit of pain during that particular appointment, and I was happy enough to do that. It wasn't that bad, I could deal with it. But I couldn't get out of the dentist's chair. The attack started again. And he said, well, look, that's the body's own adrenaline. You could have had anything that I have in this drawer, but you chose not to, and look at the result. What do I do?
Okay, I'll have several things, including that there should be something else in his drawer, if there isn't. But so let me just say a few general things about dentists, because lots of you will go to a dentist. And in Boston on the radio, we have these ads for Dr. Mark R. Turner, where the R stands for relaxation, where they basically put people under general anesthesia for these issues, and it like drives me nuts. Every time I wonder, oh, maybe I should focus more on other things. No, I said, no, I'm doing this. And so there's several things about dentists. One is that just being at the dentist releases epinephrine, and as Dr. Weber and others have mentioned, the epinephrine drives your potassium low and can trigger attacks in itself. And the reason that they give epinephrine, that the dentists give epinephrine, is not to make your heart beat faster and for you to feel anxious. It's because if you give epinephrine, it causes the blood vessels to contract a bit in that area. And so the numbing medicine, which is usually lidocaine, is more likely to stay there. So it has an actual purpose. And my dentist recently said, oh, we have a lidocaine reverser that we can give you after your dental work. And I thought, no, I don't want something else, but tell me what it is. I'm interested from a scientific point of view. And of course, it wasn't reversing the lidocaine itself. It was reversing the epinephrine, which would sort of let the lidocaine out. So that's one point about dentists, is they give you epinephrine. Epinephrine is bad for periodic paralysis. Second point is just being in a dentist chair, even if like you don't have any problems and you're just sort of imagining pain coming, is enough to get the body to release both epinephrine and steroids like cortisol. And those, as Dr. Weber mentioned, also lower potassium and raise sodium and do all sorts of things that can make periodic paralysis worse. So that's two things about going to the dentist that's likely to make it worse. Now, thirdly, there's this subset of people. So there are certain families in which people have both hypokalemic periodic paralysis and a constellation of other stuff. And the other stuff is lidocaine doesn't work. They have what's called either ADHD, attention deficit disorder, or Asperger's syndrome, or they now call it mild autism because the psychiatrists messed up the terminology, but I tried to stop them and I couldn't. And then the third factor is the females have severe premenstrual syndrome. And that's a constellation. In some families, it seems pretty clear that it travels with the hypokalemic periodic paralysis gene. We're trying, within a few days, we will be starting to sequence one of the large families that many of you have met at some previous meetings. And we hope to find what we think it'll be a variant somewhere else, maybe another gene, maybe in a promoter of a gene, and so forth. There also are a whole bunch of people who don't have periodic paralysis who have lidocaine ineffectiveness, ADHD, or Asperger's, it depends what people call it, but it's the same thing. And the females have premenstrual syndrome. So you can have a mother with severe premenstrual syndrome who has a son with ADHD. Nobody thinks there's any relation, but we're pretty convinced they are, and we can treat both of them with potassium. And we think it's a big chunk of ADHD, like we're talking millions of people. And so this is out there, but it's just so weird that nobody's stumbled upon it. And some of you folks, somebody's just saying, wow, because, oh, my brother has that, my mother has that. And there's lots of families like this. We know about you. We're starting to do the genetics. We just got an NIH grant to study just the basic phenomenon, because all sorts of doctors will tell you, I don't have anybody for whom lidocaine doesn't work, but you guys could say, no, and they gave, my brother had his toe surgery, there was like agony. And so that's a third reason. There's another group of people. So I don't know if you've had, if lidocaine works for you, or you have any symptoms that might be ADHD, or your mother had PMS or whatever. Usually guys don't know if their mothers had PMS. You have to go ask. So that's a third issue that at least for some people is about the dentist, because not only is I'm a little, like my heart rate goes a little faster when I go to the dentist. I don't have any of these things. But imagine going to the dentist and you know that the lidocaine doesn't really work well, and they give it to you a few times, and maybe it sort of works after the third injection in 45 minutes, but still it's not going to be a pleasant experience. That's going to release more epinephrine, plus they're going to give you more lidocaine with epinephrine. And so the whole thing can really wreck your day. And so the first paper we published together with one of my colleagues from Children's Hospital in Boston who was at Harvard Dental School, and I asked around and got him and others to recommend another drug aside from lidocaine, and that worked fine. And it worked fine on the kid we described who, in his toe surgery, the lidocaine didn't work at all, and the surgeon didn't believe it, and the kid was smart enough to convince us that that he really could feel it. And so there are other drugs, and so if you're so in the dental situation, I'll just mention briefly in the non-dental situation, there's other drugs that can work. So if you're having lidocaine doesn't work for you, you can get other drugs like blocking on them now, but there's a bunch of other drugs that will work. And even if you just buy the benzocaine that people use for like various sores or something, that works for these people also.
May I just add something just briefly, because this is an issue I had, and I talked it over in detail with my dentist, who was very specialist. The adrenaline issue, he says it is partly the dentist's skill, that if the nerve block is exactly where it should be, that dentist should not need to use adrenaline anyway. But he said, life being what it is, most dentists don't get the right exact place. So that if you need an adrenaline-like compound which keeps the local anesthetic in the area, so better anesthesia, use octopressin, it's called. And for those people with who are insensitive to lignocaine, it doesn't work. Lidocaine, lignocaine, same drug. There is a dental anesthetic called Cytonest, which is a combination of prilocaine, which is a lignocaine relative, but often works in people in whom lignocaine doesn't work, and a mixture of octopressin, which he reckons is a safe alternative for adrenaline in somebody with periodic paralysis. So I just thought it would be worth mentioning. I think it's found in most countries. It's called Cytonest.
That's interesting. So I forget if I mentioned the name of the drug. That there'll be different drugs available in different countries. So one that's widely available in the United States is articaine, but I think the articaine comes with epinephrine. So it's for somebody who just has all they have is ADHD variety. A little bit of epinephrine is not going to be a big problem, but obviously if you're going to be paralyzed, it is. And so this is interesting if it's. Please write that down and give it to me later, and I should know about this.
This was a lot of detail with me.
Yeah, well, that's terrific, and I mean it's one of the great things of these meetings is that you tend to get both people with medical background and just people who are smart people in general for whom this has become a big issue because it affects them and their family, and that's when I gave my first talk at one of these meetings. I described the 3 ahas that allowed us to get to this point, and one of them was from members of this group who basically told me about this whole actual overlap between hypokalemic periodic paralysis and this sensory overstimulation syndrome that we've described. And there's a lot of great knowledge out from the stuff that you know, and just because we're not mentioning something doesn't seem, you shouldn't think that it's necessarily unrelated. So one of the things that came out of one of the meetings before I got involved, but I heard the stories about it, was that the association of muscle cramps with periodic paralysis was not well described. It was certainly wouldn't appear in the review article. Somebody somewhere may have described it. But somebody asked for a show of hands at one of these meetings, and lots of people said that they had them. And it makes perfect sense given that, as you saw from Dr. Weber's talk, what is happening in this situation is you can imagine two different types of paralysis of muscle. One is that you just make the muscle completely inexcitable, as you could do just by blocking everything, and you wouldn't expect cramps with that because just nothing's happening. But what's happening here is what's called a depolarizing paralysis, where you're reducing the amount of voltage across the cell, and so that's referred to as depolarizing. And that's normally the trigger for contractions and so forth. So this is exactly the sort of situation where one does expect cramps. So it made a lot of sense scientifically, but we were basically didn't just say, hey, scientifically it should be that you would expect cramps. Why is nobody telling us about cramps? It was people telling us about cramps, and it was clear that most people had them. And what's interesting with this ADHD, sensory overstimulation disorder, is they have cramps too. And nobody defined cramps as part of ADHD, but if you go around asking people with ADHD about cramps, oh yeah, I have these really bad cramps, and we didn't know to ask about them. And I can't criticize my colleagues for not doing it because it never occurred to me either. But the way we learn these things is by listening to you folks telling us what's going on, and we know a fair amount about the science, and we put those together and can figure out all sorts of stuff. So these are hugely important for sharing these various insights, because it's not just that we can tell you what's going on, but you can tell us what is going on.
Just a quick follow-up on the dental visits. If epinephrine and cortisol go up as you're going or as you're there, can you just K up before you go, so you potassium up before you go to the dentist, and then your visit's going to be okay?
Well, it certainly would be better than not, and I would certainly, anybody who has this and anybody who has this and somebody in their family, just make sure to that you don't get the situation that Gabe was describing of just being so focused on something else that you don't pay attention to this, because absolutely I think you should make sure to be well treated before you go in. And we have some anecdotal evidence, and some of you may have more, that when people for whom lidocaine doesn't work that well, it works somewhat better if you tank them up on potassium. And so we don't think, it's not this absolute doesn't work at all. What we think is going on is lidocaine works on the sodium channels, and the whole way an excitable cell works is on the balance between, I'll oversimplify a bit, but the balance between sodium currents that are exciting you and by making the voltage more positive, and potassium currents that are inhibiting or quieting down the cell and makes the cell more farther from the normal firing point. I'm trying to use my words carefully because I know that Dr. Cannon and Dr. Weber are going to say, well, but there's also this phenomenon. But that's sort of the general, and this is the same reason that Dr. Weber referred to paradoxical depolarization, because it was surprising, but so I'm giving you the first order description. But basically what we think is going on in the lidocaine situation is that just these people are closer to their cells being excitable than other people are. And so we don't think that it's just lidocaine doesn't work at all. It's just you got to hit them harder to knock them out, basically. And so, yes, we think that if you take more potassium and make it so that this is less an issue, that you can overcome it to a significant degree. And, if you take a sort of very long-term historical perspective, what's the difference between us and our ancestors a few thousand years ago? We're eating a lot more sodium, we're eating less potassium, we're often in the air conditioning, and we're not losing as much sodium as we would in the summer and so forth. And we're setting ourselves up to be much more affected by these sorts of diseases. Now, the types of things we're talking about here in terms of people having these actual paralysis episodes are just, the tip of the iceberg of the worst part of the consequences of these things. But for the people with just the ADHD and cramps form, that's much more common, and we're seeing a lot more of that now. And part of the reason we're probably seeing it is people are having more salt and sugar and less potassium, less exercise, more air conditioning, and all these things that we associate as good things, they have their consequences.
Just a quick question from my mum relating to the dental topic, the anesthetics. She's saying that if she has a dental procedure done and she is given the anesthetics that have adrenaline in it, she can't take those at all because of her, well, firstly of her suspected ATS and her heart reacting very badly to the adrenaline part. And if she has the anesthetics that are without adrenaline, she's still getting loads of attacks. She's going to be suffering from the paralyses for a couple hours, and she's going to be numb. It's just extremely strong for her, even though it's maybe a tenth of the usual doses. So the question she's asking is there any alternative? What should she be doing? She can't always, go through that for every minor procedure when she's reacting like that.
Well, one thing you should do if you know, so certainly, this is complicated because there's two issues here, and so let me just address each of them separately. One is there's people for whom epinephrine, also called adrenaline, depending on your country, is, there's people for whom that, in fact, probably most of you, that is something that can trigger an episode because of its effect on potassium. So that is one factor, and you can ask dentists to get lidocaine without epinephrine. It does exist. Everybody can order it. It's not a standard thing, but if you tell them about it in advance, they will do it. Similarly, if lidocaine doesn't work, you can ask them in advance to order these other drugs that will work, but you can't just show up and expect that they'll have it, because they'll say, no, we don't have it, let's just try this way. And so you have to know to give them, a few days or a week's notice, and they can order these things. And when we're doing this study on lidocaine, we're going to be using lidocaine without epinephrine, just because we don't want to be studying two drugs at once. As to what you can do, it sounds like what you're describing is that some of what you're describing is due to just the fear of the episode itself. And so that may be a situation where some sort of anti-anxiety drug will help get you through it. But basically, you should make sure that you're not just causing pain and then treating that as an anxiety disorder. But so the advice would be absolutely avoid the epinephrine, but you may need to do something else to deal with the body's own production of steroids or epinephrine, because certainly going to the dentist can do both of those.
Hi, I just wanted to change topic for a minute. My brother has Anderson's, well, all my family have Anderson's, but one of my brothers is having quite a lot of problems with mobility. He's not really able to work and he's in a lot of pain. Previously, he had Keveyis when it was on the market in the UK, and then he had some benefit from it, and then it was withdrawn. Does anybody know when it might be available in the UK, or is there a way that people in the UK can buy it from the US and have it imported? Because it's not possible to do it through the NHS?
There are people who know much more about this than I am. I'm looking for Dr. Levitt. I don't see him. Oh, here he is. You can either...
Just repeat the question quick.
Keveyis,
Yes.
we need it in the UK and we cannot get it through the NHS. Is it possible for UK citizens to buy it in another country and import it, or is there news that it's going to be coming?
Okay, so unfortunately, well, back in the day when my family owned Taro Pharmaceuticals and we purchased it from Merck and developed it, I was going to make it available worldwide. But then we got hostily taken over by Sun. They raised the price to a lot. Then they said, okay, they got it kind of exposed in the papers, and then they made it for free. And then Strongbridge bought it, and but they only have rights to the U.S. market. Sun still has rights to the ex-U.S. market, and last I heard from Strongbridge, who heard from Sun, but I'm not privy to any information because I'm not part of those companies. They said they were trying to get it approved in the UK or in some European countries anyway. So I don't know where they're at with this. Your best bet is to somehow have someone in the U.S. get it prescribed for someone in the U.S. and then kind of mule it over in a suitcase. I don't know what to tell you. I mean, I've done that for people. I'm happy to write the prescription for you in the U.S., and I don't know what Strongbridge's policy is about that in terms of getting it free versus making you pay $100,000 sticker price or whatever it is for the drug. But I'll be happy to write you the prescription if your doctor says it's cool, and then you can come to the U.S., get it, and go back and do what you will, and do that every month. We can do that. People in Canada do that.
Okay, thank you.
So there's an underlying issue here, which is that to get a drug approved, you have to do these very expensive trials, and so it becomes difficult to do them for a rare disease. And one of the things that makes us very hopeful, if we can find a tie between ADHD and periodic paralysis, and then it brings in, and we know certain of the treatments are the same. We've had people who've been on potassium, others have been on Plerinone, and they work very nicely. And so one of the hopes is if we can really show that the therapy is very similar for both of these, it tends to bring in a huge market that could then knock the costs down lower. And so, that gives us some hope, but obviously doesn't solve the immediate issue.
For anyone in the UK in this room, just to say I live in Wales and I've put in an application called an IPFR, which is an individual patient funding request for Keveyis. It's not back yet, it comes back in 2 weeks' time. And if that goes through, that will be a bit of a coup because it will pave the way for any other patients in Wales to get Keveyis on an individual patient basis. In England, all of the IPFRs that have been put in through Professor Hannah's team, for example, have all been turned down. But we have a different government in Wales, so it may be that we're lucky. And if I don't get mine, I'm then going to put in one for my 16-year-old and hope that that makes a difference. So I will
These
keep
are
you
tremendously
posted.
difficult issues. I brought this to one of the Pulitzer Prize-winning journalists at the Wall Street Journal years ago when this first started with some other medication with the prices getting jacked up like 100-fold. And she didn't want to write about it, and then 5 years later it turns into a really big story with a bunch of medications. And this is an issue, and we're going to need to figure out better ways. And I think the solution, at least in the United States, is going to be to make the process, improve the process for rare diseases so it's easier to get something approved. But obviously, the turning something into a non-rare disease has its advantages, but is seldom done. Seldom can be done.
Yes, and maybe I can comment on the Dutch situation. I know that Frank Weaver also has some experience in Germany, but I'm also having very much trouble getting patients on diclofenac, and Sun Pharmaceutical is quite helpful now. But in the Dutch healthcare system, because this is all off-label treatment, right? These drugs are not indicated for periodic paralysis in the Netherlands or in Europe. It is now FDA approved, but still not in the European Union and UK for now. But it's quite difficult, and I'm going to talk about mexiletine on Sunday for non-dystrophic myotonia, and we had a similar walk to getting coverage decision. So also one of the patients then entered this application saying it's not right that this is not covered because there are randomized controlled trials that show that it's beneficial, and this is the case for diclofenac now, with 2 randomized controlled trials showing positive effects. So actually you would say this is enough evidence to get it covered. So I just want to, well, praise you for getting this on your own initiative, and hope that it will help patients with periodic paralysis as it did for the patients with non-dystrophic myotonia and mexiletine. Meanwhile, we're just hoping to get this orphan drug designation labeling for diclofenac for periodic paralysis. So that's my experience in the Netherlands.
May I just add a comment to that? I was trying to get diclofenac for a friend in a non-European country, but who doesn't have access to it. And I live in France, and I contacted Professor Fontaine's unit in Paris, and his assistant, Dr. Savine Vicar, emailed me to tell me that she is the designated European lead for diclofenac European-wide approval. Now, I know no more than that, but all I know is that a French doctor in the neuromuscular unit in Paris is the lead for getting pan-European approval, including pre-Brexit the UK. So if anybody has a doctor who can contact her, her email is easily available on the internet, Savine Vicar in Paris.
Two years ago, I could get 1 year ago, I could get the Cavies. My healthcare insurance was willing to pay for it, the $4,500 euros for Thomas, my son, and for me. But we only we had fill in a lot of papers. The only thing we were searching was a Dutch doctor who was willing to sign every year the papers. So that's the only trouble we had.
That sounds easier than most places.
Yeah, and because we have a German diagnosis, it was not recognized in the Netherlands, and still is not. So.
I mean, it's surprising that when you have a situation where you can actually say you have this variant which is known to produce this condition, and by the way, we use the term variant rather than mutation for these diseases, because what's happening, it's not that it's changed in your generation. We would call that a mutation. A variant is just something that is there that is not common. So that's why we use the term variant instead of mutation in most circumstances. But if one of the reasons we focus so much on getting a genetic diagnosis is we can say, look, they have this, it's well described. If you don't want to go read the papers, then you're not giving good care. And that's why we're trying to find, as Dr. Weber mentioned, that we have the genes for, we can find the variant in 2/3 of people who have stories like as having hypokalemic periodic paralysis. We're trying to find the other forms, and because then we can do the same analysis, we can put them into different categories. We can do things like then say, okay, the people who have this third gene, they're the ones who seem to have trouble with electromagnetic fields, and we're going to go figure out the problem there. And that's why we focus so much on the process of diagnosis, because it really, it takes the art out of what they have and puts the art, there's still going to be art in, well, what can we do about it within the resources that we have? But then it gets to the question of, you can have somebody who says, okay, we're doing the cost-benefit analysis for how much does this help and how much does it cost.
Thank you.
Thank you. I have two questions, because what Irm says, I also have this in Belgium. So we have a letter from a doctor who, from Germany, Dr. Weber, who says, you probably have this disease, but it's not recognized by the insurance in Belgium. So what do we have to do? We have a paper from a doctor, and they don't believe us.
Well, there's even a problem that comes before that, that we're having a lot in the United States, which is is somebody going to approve the genetic testing in the first place? And so we have a lot of situations where somebody could have a whole bunch of other things. You can't just do 2, 3 tests to check, as you could with periodic paralysis at the moment, where there's sort of only 2 genes that are really very convincingly associated with periodic paralysis. There's some that may have a small effect, but there's basically a sodium channel and a calcium channel gene. And so we face the issue of somebody won't approve genetic testing in general because you're looking for 20 different types of things. But typically, when you get down to the situation of, I know you have this this particular variant, the question comes up in periodic paralysis of, it's not like Kaveh is the only treatment for. If it were the only treatment, it would be a much simpler case to make. But there are other treatments, but many people have found that those won't work well, and the Kaveh is the best way. And so that's what the payers are. That's where it's getting bogged down. Is people are saying, well, is this really the only treatment? Have you exhausted other treatments and so forth? And the price tag is very high. And so that's why there's this issue, and it's basically the insurer or the country, if it's a national system, makes decisions.
It's not for that medication, but it's so when you have no mutation, you can never say 100% that you have the disease.
Well, it certainly makes it much harder to make the case, and if they're talking about $100,000 a year, if you can't prove that you have the disease, people aren't going to say, well, let's just try it. I mean, in some circumstances they may, but
in terms of, this begs the question this begs the question of the need for official diagnostic criteria. And I don't know if Dr. Weber or Steve Dr. Cannon can mention, what are the current standards of diagnostic criteria? And the American Heart Association has the American Heart Association standard for LDL cholesterol. And that's the gold standard. And it would be nice if the PPA had the gold standard for, but who are we? But we could be if we all, unified together. But so what do you guys use? Other than obviously gene testing, because it's gene testing, positive genetic test plus, Jeff's coming to you with the mic.
Well, of course, if you have a hypo-PP episode and the potassium smaller than 3.5 and you have a mutation that fits it, you have a diagnosis with certainty. And if you have the clinical picture but without these criteria, I usually use the term most probably, or from a clinical diagnosis without and yet with an unidentified mutation. So I usually call that, or unidentified variation now of clinical probable disorder. Yeah? And then I call it a possible disorder if I don't have anything like that. So I have certain probable and possible.
Because anything but certain damns someone to no medication and no disability.
This depends on the system you work in. Yeah? In Germany.
So the question, I guess the question is there like a reference? Is there, the 2015, article by the Neuromuscular Working Group, that says, and that's what, what should be the gold standard? I don't know if Dr. Kenny, you want to also?
There is no gold standard. Part of the problem is in all rare disorders, you don't have a large enough consortium of people and the resources to put together and establish something like, the Cochrane criterion or something like that. The group in Ulm has published in neuromuscular disorders, and some of those are cited most heavily, and I think the experts, there's a great deal of consensus. So that's the good part. It's not as though there's disagreement amongst the experts. The problem is, certainly for up to a third of the patients who have absolutely classical symptoms consistent with periodic paralysis, there won't be an identified mutation. And a couple of years ago, not too many years ago, it was very difficult even to have access to testing. Fortunately, that barrier is getting reduced because the cost is coming down. One of the consequences of that is now there are a lot of variants of unknown significance. And so that's a new thing to deal with. I would just add, with all of this, I'm not aware of the requirement of genetic confirmation to be eligible for patient assistance and get Keveyis in the United States. I don't think that's true.
I don't believe that's true
That's
either.
not true. Because I've been working with Strongbridge on that. And so you're not, quote, in a terrible category if you don't have that magic piece of paper that says here's an identified mutation, therefore I'm eligible for all these things. That would be a travesty if something like that were to happen. So.
Yeah.
I know there's this new review article with Jeffrey Stedland as first author, I think in Muscle and Nerve. I'm not sure if you're
that's kind of what I was alluding to.
So that's the latest criteria, but I'm not sure if they generally accept it. And also the Cochrane paper about treatment in periodic paralysis has the previous probably clinical diagnostic criteria in it. I can put it in my slides on Sunday morning.
I think these references will be helpful because for the folks who are struggling with, their doctor is neither here nor there about it, if they can at least demonstrate objectively that they meet these, published criteria, that might be your best bet at, securing treatment. If, obviously, like, I'm a dermatologist, so I actually don't treat these disorders, but if I were a neurologist, I might, think about treating people empirically, because the medications we're talking about are reasonably safe and on the spectrum of safety of meds. And, if you respond, well, that's great. Who cares what you have? If you take the medicine and you feel better, I don't care what I call your disease. It's better to know, but so I'm more of a practical person like that, but that's not everyone feels comfortable doing that. And there's a large medical legal risk also with a doctor treating something that they don't feel they know what they're doing and then just giving a medicine, and what happens if harm comes? It's first do no harm, and I guess better not to treat and let you suffer than to treat and make you go downhill, even if the flip side is maybe you'll get better, but maybe you'll get worse. So if that's unfortunately how medicine, at least medicine in the States, anyway.
There's a lot of places where things will operate according to exactly those rules, but there's different rules in different places, and so we're dealing with a whole bunch of different countries here, and in the United States one deals with a whole bunch of different insurance companies, and so there isn't a single one answer, although it sounds like there may be, the Europeans may be standardizing on this issue, and I agree it shouldn't be absolutely necessary. It's clear that for a third of the people with hypokalemic periodic paralysis, we haven't found the variant, but they look every bit as convincing as the people where we have found it. And one strategy from our point of view is find those variants, and another strategy is just convince people that they do and they should have access to all appropriate treatments.
Dr. Segal, I have a note here, a question from online. I am ATS2, lidocaine insensitive, and affected by EMF. I find that I need to monitor my mental exertion the same way I need to monitor my physical exertion. So I plan the way and how much I read, study, with the level of difficulty, etc. I set a timer for 15 minutes when I'm reading something technical, and intersperse it with easy physical tasks like gardening, etc. My medical alert dog is very tuned into it as well. Lidocaine not only doesn't work, but it causes heart pain.
Well, there's, it's clear that any type of stress is a trigger. And so it could easily be for some people that the stress of doing very difficult mental things is, releases, if you had a sensor in somebody's vein and you could measure their amount of epinephrine in the blood, it would not be surprising that would go up under these circumstances, and it would not be surprising that it would have an effect, just like going into a dentist's office. It can affect you, make you more likely to have symptoms just because of the stress involved there. So it seems like a reasonable strategy, and it may sound a little extreme to some of you, particularly those of you who ride hundreds of miles on a bicycle, but the people for whom lidocaine is ineffective they're much more sensitive to some of these things than others, and so I think it's important to keep that in mind. And when somebody tells me that their lidocaine is ineffective for them and they have these symptoms that sound like much more extreme than other people's symptoms, my attitude is that that's what it seems to be from what we hear from other people.
Apparently helps if you turn it on. What we're going to do is we're going to stop right now, but thank you very much for talking and leading the discussion. So let's hear it for Dr. Segal.
One more thing related to a question that's come up, which we'll try to illustrate, is the whole question of how doctors make a diagnosis. That when I talk tomorrow morning, I'm going to try to give you a feeling for what's going on in somebody's mind doing that, and I'll use diagnostic software to illustrate that. Because there's two ways we make diagnoses. One is we have a set of criteria, but that tends, as Dr. Cannon said, that tends to be what we do for big established diseases where we put together committees and stuff. What actually happens in people's minds is life is much more varied than those guidelines. And we tend to go through what we call a differential diagnosis of the various diseases. And so I'll try to illustrate that using software and using an example of periodic paralysis, and then go on to show you how this can be used as the front end to genome analysis, which is ultimately how we figure out which of the known or which of the unknown diseases that you have.
Thank you. This is just the token gift. Thank you so much.
I've a previous token gift of a windbreaker that can fit in about this size packing was extraordinarily useful the last few days in Dublin.
Good, that was pretty cool. That was a cool gift. This isn't as cool, so sorry.